Assalamu alaikum. I am Dr. Maham Khalid, the co-director of the academic wing of ventilators for Pakistan, and I welcome you all to the second session of medicine for our COVEB series. For all new attendees, I would like to mention that this is part of the educational activities taken up by Ventilators for Pakistan, which is a non-profit organization set up by our founders Dr. Sabah A.K. Akhtar and Dr. Rabail Tariq, with the goal of donating ventilators to various hospitals across Pakistan and to eventually improve the critical care of the country. I am proud to say that so far we have donated 8 ventilators to government hospitals in Pakistan, with a recent one donated yesterday to a teaching hospital at Kuzdar, Balochistan, where we will also be setting the first EICU of Balochistan in the coming week. VFP has many teams working on different voluntary projects, including procurement and donation of medical equipment like ventilators, establishing EICUs, free internship certificate program for undergraduates and young doctors that teaches them how to use EMR, free awareness campaigns on COVID-19, free webinars to educate and update doctors and other healthcare workers. Last but not least, helping on a community level by donating oximeters, oxygen concentrators, etc. via our home management plan. All of this would not have been possible without the efforts of all the members of the FP. Now, I would like to introduce the co-director of the academic wing and my co-host for the evening, Dr. Mahmoud Sharfi.
Thank you, Dr. Maham. Assalamu alaikum. It is an honor to co-host the COVEB education series. I'm the co-director of the academic wing for VFP and also the co-founder for Yardim Foundation. Yardim itself means help in Turkish, and my sister and I founded this organization about a year ago with the sole intention of helping our nation in whatever way we can, specifically orphans, widows, disabled, and other marginalized sections of the society. We currently have 3 running programs. The Yardim Dental Program is our pioneer initiative under which we organize the dental camps. This is done to create oral hygiene awareness, conduct free dental screenings, and also provide free dental treatments in underprivileged communities and school. We also have a mental health awareness campaign running on ground and online, the agenda of which is to spark a conversation which will help tackle the stigma in our society and also provide information and support to people suffering from anxiety, depression, PTSD, and more. Our third and final initiative, FRP, is a food and ration program, which we started during the pandemic and have so far helped 800 plus families during the lockdown. Over to you, Dr. Maham.
Thank you, Dr. Mavish. It would be remiss at this point to not mention the personalities without whose patronage we would not be able to host our series. Our patron-in-chief, Professor Emeritus Lieutenant General Mahmood Ahmed Akhtar, is a reputable and widely recognized expert in the field of medical sciences. He is an outstanding medical specialist and an excellent researcher, having authored over 500 publications and 4 books. He served as a medical specialist in the armed forces in various roles, including Principal of Army Medical College, BT Medicine, and as Surgeon General of Pakistan Armed Forces. He has been awarded Hilal Imtiaz Military and has been honored with the title of Professor Emeritus for his services to the country. Thank you, sir, for accepting the role of Patron-in-Chief of these webinar series. Our patron, Professor Samia Naeemullah, is a well-known and prominent pediatrician and a teacher of teachers. Professor Samia was the head of Department of Peds at Rawalpindi Medical University and at Rifa Medical University. She is the recipient of the President of Pakistan Gold Medal by Pakistan Pediatric Association for outstanding contribution and services in pediatrics, education, and research, and has also been awarded Best University Teachers Award by HEC. She has been the president of Pakistan Pediatric Association for 2 years and a faculty member of CPSP. Thank you, ma'am, for accepting the role to be patron of these educational series. Now, without further ado, I would like to call upon stage the first speaker for tonight, who is Professor Zileh Humayun Mirza. He's a graduate of Army Medical College. He's the head of Department of Pulmonology at Pakistan Emirates Military Hospital, Rawalpindi, and the professor of medicine at Army Medical College. His topic for tonight will be management of COVID. Sir, over to you.
Can you see the screen?
Not yet, sir.
Is it visible now? Is the
Sir,
screen
you have to press screen share screen.
okay? It doesn't seem to work.
So you have to share screen by pressing on the share the screen button.
Can you see now?
No, sir.
Not yet.
Sir, would you like us to share it for you?
Please, if you can help.
Yes, of course, sir.
Sure, sir. We will be showing the presentations for you, and you can tell us when to change the slides, and we will be able to change it.
Okay. Let me know when it's done.
Sir, can you switch to the PowerPoint?
Yes. Do you have it on screen?
Yes, sir. Sir, if you just open your
Yes, sir,
PowerPoint,
just a moment.
you can see your desktop right now. Kindly just open your PowerPoint and then we'll be able to share it.
Is it working, please?
No, sir, not as yet. Dr. Maham, maybe you could share it? Sir, we can see it.
You can see it?
Yes, you may start.
Okay, great. Should I start now?
Yes, sir.
And would I be able to change the slides or will you do it? Okay.
Dr. Maham will be able to. You can tell her to move on to the next slide.
Okay. So let's start the activity after much ado. I'm very thankful to this whole initiative of getting knowledge out there, and that too doing free of cost and in a selfless manner. May God bless all of you who are responsible for all this. So, just to keep it simple, uh, how do we learn together in times of more like a pandemic rather than a pandemic? Next, please. Uh, yes. So the more I know that I don't know is usually what is the verdict for as far as COVID is concerned, because none of us is sure how to tackle it. The disease process is just about 7 months or so long, and we are still learning to build the car while driving at maximum speed on a highway, in a matter of speaking. Next, please. So some of the myths busted. Next, please. May I have the next slide, please? Yes. So to start with, we know now that there were three strains of corona. The initial A strain, which mutated twice to turn itself into the daughter B strain, which we believe came to Pakistan and the subcontinent, and the C strain after another mutation, and that is the killer strain that probably went to Europe. And after that, may I have the next slide, please? By now, we have the two major variants, the D variant and the G variant at present, which just have an amino acid change at 614 location. And the G variant has now practically taken over the world. It is a more rapid grower. It transmits itself more rapidly, about 6 times or so, and has a stable S protein, and will probably not require the cleavage protein TMPRSS2, which I'll show you in a couple of minutes. So at present, the scientists believe that the G614 variant is what's doing the rounds in the whole world now. May I have the next slide, please? By now, this is a very common slide which is doing the rounds on the internet, and I'm sure you must have seen it. On the left-hand side, if you can see, it shows the symptom-wise distribution in terms of the percentage, the asymptomatic, the mild ones taking up most of the percentage, and some bit of severe and the critical ones. And on the right-hand side is the dreaded complication that made the world forget everything else and just concentrate on COVID. And the death percentage rises to about 50% in the critical group. And another thing that you should appreciate on this slide is that the contagiousness or the infectiousness of this virus depends on the symptomatology. If it's a mild symptom, the infectious period is about 10-11 days, which can rise to 14 and to a much longer duration if the disease goes critical. May I have the next slide, please? This is one of my favorite slides because it clears up quite a number of concepts, and in it, as you can see, that the different phases of symptoms are shown: incubation period, the symptomatic, the early pulmonary, and the late pulmonary phase. And if you concentrate, the viral replication dwindles from early pulmonary phase into the late pulmonary phase. And by now we know quite a number of studies have proven that beyond 10 to 11 days of illness, the virus takes a turn for the worse, and it is not transmissible or it is not infectious. And after day 11, what the PCR detects is usually the dead pieces of tissue which are not replicable in the lab and are not contagious to other persons. And in the orange color, you can appreciate that the whole problem from day 11 onwards is the dysregulated immunity, which starts from just a bit of good innate immunity and then progresses itself to immune dysregulation, the secondary HLH, hemophagocytic, lymphohistiocytic reaction, the cytokine release storm, and maybe even to macrophage activation syndrome. And in the bottom part of the slide, if you can appreciate that the antiviral therapies are mentioned. So the immunomodulators, which are supposed to work on the virus, and the antiviral medicine itself, if you can understand this pathogenesis, they are supposed to work in the first 10 to 12 days and not thereafter, because the virus is no more viable after this period, and hence there is no need or requirement of prescribing an immunomodulatory or an antiviral drug after that. After this initial 10 to 12 days, what works are the immunosuppressants and the other immunomodulatory therapy, which I'll show you later on. May I have the next slide, please? And the same message is given in this slide, that soon as the oxygen saturation starts to drop, the one red line curve, that is the time that you should start anti-inflammatory therapy. And if it takes a turn for worsening, then you should escalate the anti-inflammatory therapy early on rather than late. And that is the time where this anti-inflammatory therapy will help the patient best. May I have the next, please? This is a very important and an interesting study that came up just recently, and by now it has been shown that chromosome 3 gene cluster has been identified as the major risk locus for respiratory failure in this infection. And this is the work of the COVID-19 host genetics initiative. And the risk is conferred by a genomic segment of 50 kilobytes, which is inherited from Neanderthals approximately 60,000 years ago. That is what by now science believes that we have to blame for our ancestors. So, next slide, please. Body versus alien. What seems to work? May I have the next, please? So this is the combination of ACE2 receptor and a cleavage protein by the name of TMPRSS2, which when coexist in a cell are responsible for viral entry into the cell. Both have to be present in the same cell for the virus to enter. May I have the next, please? Okay, so, and the science tells us that ACE2 and TMPRSS2 both are co-expressed in the ciliated cells, especially the nasal cells, the type 2 pneumocytes, and the ileal enterocytes. Hence, the GI tract and the pulmonary tract are the main things that get hit once the virus gains entry. And their expression is increased by age, male gender, and smoking exposure. So despite an initial study that thought that smoking somehow prevents the disease from occurring, by now we know as a scientific fact that the case is opposite. So smoking propagates COVID disease. May I have the next, please? And if you can just learn these 5 lines, I'm sure your life will be much easier while dealing with COVID patients. Science shows us that the underlying process is mainly a multi-organ, viral-triggered, vasocentric, hyperimmune, and endothelium-driven vasculopathy. So this vasculopathy occurs in all the organ systems of the body and is responsible for their shutting down and all the disease process that occurs. And the main mechanisms behind are hyperinflammation, hypercoagulability, and hyperhypoxia. May I have the next, please? So the hyperinflammation cascades, which starts by a virus triggering the inflammation, but then the whole fault is that of body because it forgets to shut the inflammation down. And from a normal and adequate surge response, the systemic inflammatory response system, which usually helps the body to deal with such infections, The inflammation passes through a cascade of cytokine release storm, secondary hemophagocytic leukohistocytic reaction, to the much dreaded macrophage activation syndrome. These are all on a single spectrum of inflammation, and mass is the most dreaded complication of it all. And the next, please. Next slide, please. Yes. Coming on to the main hit, the pulmonary system. So now we know that the main issue in lungs is a severe VQ mismatch, which is due to a large intrapulmonary shunt, which is thought to be partly due to inflammation-driven thrombotic complication and partly due to other mechanisms. And the mitochondrial redox system, the reduction oxidation system, which is in vascular smooth muscle, is the main hit, along with the body sensing mechanism, which results in impaired hypoxic pulmonary vasoconstriction system. Just to remind you that the normal response of the body to such an insult is vasoconstriction. Whenever the body faces hypoxia, the lung vasculature vasoconstricts, which results in a bit of increased flow, and it maintains the oxygen saturation. But in COVID disease, that mechanism is impaired. And since the virus is of 21st century, it has learned some tricks as well. So where it upregulates all the bad cytokines and chemokines, at the same time it remembers to downregulate the expression of one primary antiviral host defense system, interferon alpha. And this is the scientific reason where Chinese and some other countries have tried nebulization of interferon alpha as a therapy to thwart the pulmonary complications. May I have the next slide, please? So CRS, I'm sure you can all Google it up and see. Just to recapitulate the diagnostic criteria, it is a fever of unknown origin for more than 2 days in the absence of bacterial infection, along with either a ferritin of more than 1,000 and rising trend, or a ferritin of more than 2,000 in a patient requiring oxygen, or lymphopenia less than 800, and two of the following: ferritin less than 700, LDH more than 300, DDAN or more than 1,000, and a CRP more than 70. And if any of the three or above are present on admission, there is no need to document a rise. So these are the different parameters of cytokine release storm. May I have the next slide, please? Some even go further to grade it on the disease of on the severity pattern and systolic blood pressure, saturation of oxygen, and the number of organs involved dictate how severe the grade is. These are all available online, so I'll be skipping the things and concentrating on what I believe the knowledge you should have. May I have the next slide, please? And this is the secondary HLH that we experience. It is defined on the basis of 2004 criteria as a fever along with splenomegaly, any two of the cytopenias with raised triglycerides, fibrinogen, and a ferritin, or hemophagocytes documented on bone marrow, spleen, lymph node, liver, and even, if possible, on blood. The NK cell activity and the soluble CD25 enzyme activity are usually not available, so we can forego them. And if the rest of the criteria are fulfilled, secondary HLH is thought to be present as the major problem in the body. May I have the next slide, please? And this is the final, the worst outcome that a body can experience, the macrophage activation syndrome. This is basically interleukin-1 beta driven, and a single parameter of ferritin of more than 4,400 is thought to be diagnostic. However, raised AST, ALT, and an increasing CRP are also documented in it. And as you can extrapolate from your thinking process that obviously high dose steroids and plasma exchange are supposed to help in such patients. And Anakinra has been tried with some success in such patients as well. May I have the next, please? So after all this scientific knowledge, what we thought how to proceed as far as our institution goes, I'll show you what we did. May I have the next, please? So these are the possible therapeutic mechanisms which various drugs are supposed to hit, from temperance and ACE2 tempering to disruption of the fusion of virus with the cell membrane, to disruption of the RNA polymerase translation, to the release, to the dampening of cytokine release storms. These are the various mechanisms and the various drugs which are thought to act at various points in the cell cycle. May I have the next slide, please? So, no surprises here. We picked up the WHO and the international as well as national guidelines and more or less just tweaked them to our favor. And we described the mild disease as the mild symptoms with no oxygen requirement and no radiological abnormality. We divided it into two categories, A and D, A being with no comorbids and a younger age group, and D being the patients who had some comorbids or whose age was more than 65. Next slide, please. And the moderate disease was the patients who had a positive radiology, X-ray or CT scan, and a normal oxygen. And in the criteria, we put down the unilateral or bilateral pneumonia, but infiltrates less than 50% of total lung fields on peripheral involvement, and CRS may or may not be present. May I have the next slide, please? And in severe category, we included the patients who had severe symptoms along with a positive radiology and who required oxygen to maintain a saturation of more than 93. And COVID pneumonia with or without cytokine release storm with evidence of hypoxia was described as patient having fever with either confusion or restlessness, hypoxemia, raising AA gradient, a PF ratio less than 300, saturation less than 93, respiratory rate more than 30, lung involvement more than 50%, or a 50% progression on radiology in 24 hours. May I have the next slide, please? So this is the basic template of our treatment procedure, what we did with these patients. We divided the therapies and measures available to us in standard of care, additional measures, and some immunomodulatory drugs. To the mild A category patients, we offered vitamin C, vitamin D, calcium, and zinc. All of these have shown modest improvement in various studies, and they don't have any particularly debilitating side effects, so they were given. And additionally, we catered for hydration, despite the fact that initial studies that came out of China and the rest of the world advocated drying up the body. But we knew that once the multi-organ dysfunction syndrome has set in, there would be very little that we can do. And hydration and maintaining of euvolemia was a better approach. Anxiety was a very palpable anxiety in all the patients that we encountered. It was the fear of death, the fear of leaving their near and dear ones behind, the fear of seeing everyone around them totally hooked up to this white personal protective equipment, and the fear of death was the most of all. So we catered for anti-anxiety as well. Melatonin we offered to any person who had difficulty in sleeping, and famotidine and thiamine on a case-to-case basis. Along with the routine vital signs, we monitored their call score and RAS score. I'll be coming to them in a couple of minutes. And we tried hydroxychloroquine despite the yo-yo effect that you all know, that one day the studies are published in favor of them, the next day not so. And still, I believe that in the last week or so, Spanish study has come out in their favor, while a Brazilian study has come out not so. So the verdict, as far as a randomized controlled trial for hydroxychloroquine or chloroquine is concerned, still is out. What we experienced is that we initially gave hydroxychloroquine to almost all of our patients, starting from February, March to April, and then we conduct. By the way, we gave all these immunomodulatory drugs as a trial after taking consent of the patient, and no patient was advised these medicines outside of the trial. So in the first couple of months, in March and April, we found out that there was hardly any difference in the outcomes in hydroxychloroquine versus the non-hydroxychloroquine group. So after that, we abandoned the use of hydroxychloroquine. Ivermectin we tried in a very limited fashion, and again we found it no good than without not prescribing it. So we abandoned that as well. And in the mild category B group, along with the same measures, we went for strict control of comorbids and atorvastatin statin and lopin in selected group. Who had ischemic heart disease, especially. In the patients who had ischemic heart disease or some arrhythmias propensity. Can you see the slide, please? Yes, I have it back. Coming on to the moderate category, the standard of care remained the same. We added awake proning for up to 4 to 6 hours, along with a prophylactic dose of Clexane and IV methylpred of 40 mg OD in the moderate. Just to remind you, the moderate category was the one where less than 50% of radiology was involved. However, oxygen need has not set in yet. So we went for early prophylactic anticoagulation and early immunosuppression in these patients, thinking that once the radiology is involved, and if you recall, the radiology is the typical of COVID is a peripheral, bilateral, and basal involvement. And as pulmonologists, we all know that this is the typical site of usually the body reacting to any antigen. So, based on our experience with treating cryptogenic organizing pneumonitis and eosinophilic pneumonias, which occur in the same place and which respond to methylpred, along with numerous studies, especially the one by the Math Plus group in Virginia, USA, we went for early Clexane and early IV MP, and it served us tremendously well. Monitoring is there are no surprises there. Same call and RAS score was monitored, and immunomodulatory drugs the same thing. And Remdesivir in the novel therapy part, we'll touch all these later on. But we had available Remdesivir, convalescent plasma, and therapeutic plasma exchange to us in the moderate group as well. May I have the next slide, please? In the severe category, we switched to IV vitamin C in higher doses, along with vitamin D for up to 3 days, calcium, zinc, same, and awake proning, the same up to 16 hours, and Clexane ranging between 40 to 60 milligrams twice a day, depending on what the patient's oxygen saturation was or how his radiology behaved. We focused on that, along with oxygen and obviously CPAP. And in additional measures, along with the previous ones, we offered atorvastatin, magnesium sulfate, single to 2 doses, and methylpred we went from anything between 60 to 120 milligrams twice daily. And obviously in selected cases, if the test turned out positive or if we thought that there is a concomitant viral or a bacterial infection, Tamiflu or Marinum was considered. And in the monitoring, along with hypoxemia, we went for CRS markers, the cardiac, the neuro markers, along with the respiratory viral multiplex. It is a test which detects up to 22 respiratory viruses, and some of them have some different treatment available. So we got benefit if it turned out to be positive. And we tried a level best to get either bacterial, fungal, or TB cultured from any secretions that we could lay our hands on. And novel therapies in the severe group, we expanded our already rich armamentarium of Remdesivi, convalescent plasma, therapeutic plasma exchange to tocilizumab, and in selected few cases, mesenchymal stem cell therapy as well. May I have the next slide, please? So as far as oxygenation goes, we knew about happy hypoxia from earlier on, and we catered for that. And especially we focused our attention in the mild and moderate group to find out the subset which was progressing rapidly, and we went all out to prevent the progression in them. This 10-step desaturation test is an indigenously conceived set of parameters along in which one of them is a fall of saturation of 5% on walking just 10 steps. We found it to be an invaluable early predictor of this disease progression in mild and moderate disease. And we targeted a saturation of 93 in the first week and 90% in the second week onward. And for the facilitation of all of you, I have laid down these steps which we followed. We kept our mind on the target saturation, and we rotated the whole of oxygen around that. That if the patient required 1 to 4 liter of oxygen, gave through nasal prongs. More than that, we switched to face mask. More than that, we switched to non-rebreather mask. Unfortunately, we didn't have access to high flow nasal oxygen. So we had to content ourselves with a combination of CPAP or BiPAP along with oxygen. And if the patient failed in a target saturation, even on that, we had to tube the patient. So the baseline was focus was on achieving a target saturation, and the focus was not on giving oxygen just for the sake of. And the time to move on to the next target was 5 to 10 minutes at best, or maybe a bit longer. However, if the patient failed trial of CPAP and oxygen of even in 1 to 2 hours, we went for early intubation in such cases. May I have the next slide, please? And when the patient was stabilized, a week, 5 days down the line, the and again we knew that oxygen toxicity was the main issue we could face at this point in time. So we focused on a saturation of 90% only, and we gradually de-escalated FiO2 initially, followed by CPAP to achieve a target of just 90% of oxygen if we could, and very gradually even at that. May I have the next slide, please? This is a busy slide. It is taken from Boston Medical Center, and you don't need to focus on anything. Just know that this slide tells us that we have to anticoagulate early and anticoagulate to the full spectrum if the patient's condition deteriorates. And even some studies vouch for supratherapeutic doses of anticoagulation on the maximum weight, based on the maximum weight of the patient, even up to 80 milligram of enoxaparin twice daily has been recommended in various studies, because one of the main focus of the disease process is procoagulant state. May I have the next slide? Coming on to the monitoring aspect, next please. CRP, ferritin, and D-dimer served us well throughout the disease process. And in patients receiving IV vitamin C, we knew that point-of-care glucose monitoring with AccuCheck or such tests was falsified, and it resulted in high blood glucose values. Therefore, we relied on laboratory glucose levels. And we monitored QT interval and magnesium if we were using azithromycin. And dropping lymphocytes and platelet was an indication of disease progression, along with the same CRS markers and the HLS markers that we focused on day-to-day patient care. May I have the next slide, please? TROPI and D-dimer correlated best with hidden pulmonary embolisms, while pro-BNP correlated with congestive cardiac failure or cardiomyopathy. And if we had to resort to echo, global ischemia was the usual finding instead of regional. And to rule out sepsis, procalcitonin and lactate levels were measured. And IL-6 levels we had access to in the last 2 to 3 months, and we found them to correlate with CRS severity quite well. May I have the next slide, please? And as far as the main concern, the respiratory compromise is related, the earliest signs that we could pick were falling PaO2 values and a rising AA gradient if ABGs were done, or a fall of saturation less than 93, respiratory rate more than 24, radiological lung involvement more than 50, 10-step desaturation test of more than 4%, or we could calculate the effective shunt fraction through algorithm available on this site. And just for the sake of all of us being a resource poor country, may I have the previous slide, please? Being a resource poor country, we found this equivalence of PF ratio to SCO2 over FiO2 ratio quite helpful, and it correlates quite well. So if you cannot do ABGs, or you don't have access to ABGs, or the patient is not willing or can't afford, SCO2 over FiO2 ratio is a quite nice surrogate marker. May I have the next slide? And this is the subset that we dreaded the most, and on which we worked the most, and on which we kept a daily and almost an hourly monitoring eye, in which the AA gradient progressed more than 25% from baseline in 24 hours, or the requirement of oxygen increased, or the PF ratio fell, or the PO2 ratio was less than 60, or who didn't improve despite oxygen and 1 hour of CPAP therapy, or who had a 50% progression of lesion on imaging in 24 hours, along with these lab parameters that by now we are all very familiar. May I have the next slide, please? And numerous studies have shown that these are the mortality predictors, which just tell us that these subset of patients should be worked upon in a more efficient manner if the dreaded possibility of mortality has to be averted. May I have the next slide, please? So these are the prediction scores that worked best for us. The COVEB score, it was developed by Chinese, I guess, and it has just 4 things: comorbidities, age, lymphocyte counts, and LDH as presentation. And it classified the score into 3 levels of risk of progression. May I have the next slide, please? And these are the scores and their points, which classifies them into 3 classes, with the risk of progression of 10%, up to 40%, and more than 50%. Next slide, please. And this is the RAS score that we indigenously developed, and it has served us well as a respiratory progression prediction tool. It again comprises of just 4 parameters: a respiratory rate, resting oxygen saturation, a 10-step desaturation, and an AA gradient. May I have the next slide, please? This is an old scoring system which predicts mortality, and it is not restricted to COVID, but it encompasses all the pneumonias that can occur, and it has 6 parameters: multilobar infiltration, lymphocytopenia, bacterial co-infection, a smoking history, hypertension, and age. And value of more than 12 put the patient in a high risk of mortality up to 34%. Next slide, please. This is the Math Plus protocol that I was telling you about. It has been developed by quite a number of educated people in the USA, and it comprises of main thrust of 4 steps: IV methylpred, high dose IV ascorbic acid, thiamine, and full dose low molecular weight heparin, along with the hematinics that are written before. May I have the next slide, please? So coming on to the novel therapies, Remdesivi we recently had our hands on, and it was only available to us in the last month or so, and cost and availability was an issue. And as by now we all know that scientifically speaking, it is supposed to work only in the first 10 days or so. So by now we have given it to, I think, about 15 patients or so, and all of them have shown a better response compared to those whom we didn't. Favipiravir has been touted as a better alternative to Remdesivir because of its low cost. However, still it hasn't been made available to us despite pharmaceutical company probably trying its best to manufacture it even in Pakistan. Maybe it's at some stage or so. Convalescent plasma, there was quite a hype about it from the initial part of the disease process or so. And people have tried using it in all steps and stages of the disease. However, you should bear in mind that in the first 10 days or so, when there is a viral phase, when there is a virus available, convalescent plasma just gives you ready to use antibodies. And just like rabies or snake bite, where initially you give immunoglobulins as well, based on the same mechanism and same theory, it is supposed to work in just the initial phase when the virus is present in the body. However, if cytokine release storm kicks in later on, after 10 days or so, or in the rapid progressive subset, and if in that subset you prescribe convalescent plasma, you are adding fuel to the fire because the body is already full up and pumping with haywire immunoglobulins and antibodies, and you are giving it more antibodies, which would result in drastic effects. And obviously, the main issue is appropriate titer on the donor, which is still in very restrictive setting it is available, and the technical know-how. Tocilizumab has been used with a varied measure of success in quite a number of patients. We restricted it to the patients who had cytokine release storm documented, and we obviously had to rule out sepsis by doing a procalcitonin level, which had to be normal, along with ruling out hepatitis B, TB, and lactate level, which has to be raised, or CRS marker, CRP, quantitative CRP, which we took as a surrogate marker of interleukin 6. So in patients or in settings where interleukin 6 was not available, CRP can be taken with a pinch of salt as a surrogate marker. Again, tocilizumab we have given to quite a number of patients, and in the critical subset, it was a very difficult decision to make to give tocilizumab because they were already in a setting where secondary sepsis was supposed to be more common. They had all sort of tubes, and in all the ICUs, Acinetobacter is more rampant than the doctors and nurses present there. So if we tend to give tocilizumab in such patients, we were immunosuppressing them additionally for the next 4 weeks or so. That is the half-life of tocilizumab. So it was a very difficult decision, and we had a committee formed which took all such decisions on whom to give and not to give. And obviously, in the phase of a trial, anakinra was not available to us and still not is, so we haven't used it. Interferon alpha, the Chinese have good success with it, but unfortunately, with the advent of oral therapies for hepatitis C and D, none of the companies kept a stock of interferon in Pakistan, and we couldn't find it, and hence we haven't used it. Therapeutic plasma exchange is a success story as far as our institute is concerned. We used it in severe pulmonary patients, in the rapid pulmonary progressing patients, and in cytokine release syndrome. And with less than 1% of complication rate, we found it to be quite useful in halting the progression. And we have a publication underway, which I hope and pray would be published soon, in which mortality benefit has been shown in severe and critical subsets. Mesenchymal stem cells, our center was one of the very lucky few which had access to some doses of mesenchymal stem cell. And we have used it in some patients with a good measure of success. May I have the next slide, please? So the war isn't over if you think that you have dealt with the mild, the moderate, the severe cases. By the way, I haven't touched critical cases because I believe my good friend Dr. Omar Rahman from USA would be speaking soon, maybe the next week, on the topic. And he obviously is more educated than me on the subject. This is a subset of patients which we labeled as simmering CRS. We have recently found them and started looking at them, and I'm sure all of you who are dealing with such patients would have such stories where the cases are now presenting in the 3rd, 4th, and 5th week, along with mild and lingering symptoms of low-grade fever, headache, myalgia, and minimal oxygen requirement. These, we believe, are the weeks of complication of the disease, and myocarditis, pericarditis, pulmonary embolism, thromboembolism anywhere in the body, certain ARDS, and supra-infection with either bacteria or fungus is the rule here. And what we are able to pick up as the early signs of this ongoing simmering CRS are the ALC ratio, absolute lymphocyte count of less than 1, a raised troponin I value, rising resting tachycardia, thrombocytopenia in a decreasing trend, and rising ALT and urea. And still now we haven't been able to understand fully how to tackle with, but these are the measures that we have tried with variable success. We have escalated the treatment based on cultures or other lab parameters. We have tried antibiotics. We have given them novel therapy if they were not exposed to it before. And we believe that these should be offered early if we are to prevent the chronic complications. May I have the next slide, please? So the long haulers and the complications that are all the world is now beginning to see are the fatigue, the transient desaturation, myocarditis, thrombosis everywhere, the most dreaded complication, myopathy, neuropathy, simmering CRS. And in Pakistan, it can be triggered by any illness, malaria. We have seen falciparum as the cause of triggering of CRS. We have seen enteric fever. We have 2 patients in whom we found out TB, in whom we did wrong with all the protective gear, and we got gene expert. We got lucky and got gene expert positive, and influenza. PTSD, post-traumatic stress disorder, is one of the main things that you should all be looking for in those who survive this dreaded illness. And lung fibrosis, we are just seeing, I believe, the tip of the iceberg. It has been attributed to maybe acute fibrinosis along with organizing pneumonia, maybe post-ARDS, but we believe it is more due to our indiscriminate and irrational use of oxygen, the oxygen toxicity that is causing the lung fibrosis. Hence, the chart of oxygen that I showed you, that we should be all aiming for some target rather than giving oxygen indiscriminately to all. May I have the next slide, please? So thinking beyond COVID in those patients who don't respond to main therapies, is it fungal infection? Is it a non-COVID respiratory viral infection? Is there any bacterial superinfection? Is it a reaction to some drug that we gave or a reaction to novel therapy? TB, pneumocystis carinii, we have 3 patients confirmed pneumocystis who were not responding to steroids, and then we switched them over to Ceptran and they responded. Is it lung fibrosis, permeembolism, arrhythmias, or any number of drug interactions? We should all be thinking about that. May I have the next slide, please? Case for antibiotics is based on the scientific evidence of a paradox of hyperinflammation and simultaneous immune suppression because of a major decrease of HLA-DR on CD14 monocytes, rendering them useless to respond to in an efficient manner to this infection. Secondary bacterial infection is not uncommon, and azithromycin has, in addition to being an antibiotic, immunomodulatory properties, including the downregulation of IL-6, which has been documented. May I have the next slide, please? And a bit of advice on the critical subset that we give is slow taper off of steroids over 4 weeks, and if the patient is on anticoagulation, you should not be in a hurry to decrease them. Again, 4 weeks is the target. Maintain the hydration well, slow daily regular walk that the patient can afford to do. Do cater for anti-stress, be it anxiety, PTSD as a CRS sequelae. And melatonin for sleep has to be given. And last of all, I used to say to all my patients on discharge that behave as if you are an 80-year-old for the next 4 weeks. Walk slowly and treat yourself well. Don't be a hero in resuming your work or activities of normal daily life too soon, because it's a virus and viruses have a bad habit of lingering on in the body. May I have the next slide, please? Oh, another thing, it's a mild disease, this head. Don't worry, this head, and let's see what we find. May I have the next slide, please? This was just published a couple of weeks ago, I believe, and it's based on some observations by doctors at Sinai Medical Center in USA. The next slide, please. In it, the doctors found that in those patients who were considered mild, who were not even hospitalized, and who were as young as 30, in those incidents of blood clotting and severe stroke was quite rising to alarming levels. And they had planned now to give anticoagulating drugs to all such patients who have a rise in D-dimer subset. May I have the next slide, please? And you have to read it to understand it fully, that they surveyed a group of patients who reported enduring and lingering symptoms including fatigue, shortness of breath, and chest pain. And 91 of those patients said they were not hospitalized, and this suggested that while they considered themselves healthy before COVID, only 6% of them vouched for being healthy after 1 month of the illness. And mind you, these are the mild cases who weren't even hospitalized that we are talking about. Next slide, please. And they found all sorts of symptoms, including facial paralysis, seizures, hearing and vision loss, headaches, memory loss, diarrhea, weight loss, and other symptoms in these mild subsets even after 1 month of illness. The next slide, please. So just a few words, radiology, virus versus inflammation. I'm sure other learned people before me would have touched upon this subject, but just a few slides. The next slide, please. We know by now that ground glass, bilateral, posterior, multilobar, and peripheral distribution is the rule in COVID. And just keep in mind that all these sites and ground glass are the patterns that the pulmonologists see in those patients who have cryptogenic organizing pneumonia, eosinophilic pneumonias, and generally the hypersensitivity pneumonias, and all these things respond to steroids as well. The next slide, please. In the right-sided column, you will find the atypical findings that the apical distribution, lymphadenopathy, cavitation, tree and bud pattern, or pleural effusions was unlikely as a manifestation of COVID to be seen. May I have the next slide, please? And if you can go through all these slides, and since I don't have the luxury of interacting you at present, so just let me straight away tell you that in the cut sections labeled E and F, the ones on the right side, these are the ones which were initially thought to be due to COVID, but were later proven to be due to influenza A. So you can see that there is just a subtle bit of difference, which nobody can say for sure between the COVID and the non-COVID viral pneumonia. The next slide, please. And in the same breath, in the right side of the picture, you can probably appreciate air crescent sign in the consolidation. And on the left side, the white consolidation. In the white consolidation, maybe you can all appreciate the rounded black spots, which are due to, supposedly due to anaerobic infection and air. The next slide, please. And this is an X-ray of an influenza patient taken from internet, which shows an opacity which starts from the center and goes up to the periphery, unlike the totally peripheral picture seen in COVID. The next slide, please. And if on this slide where the arrowheads are, if you can appreciate a white dot embedded in a black space. Yes, this arrow, please. So this is the picture of constrictive obliterative bronchiolitis, which usually occurs as a consequence of viral illness, and again which responds to steroids. Next slide, please. And this is a slide of a patient suffering from respiratory syncytial virus. And compared to COVID, I hope you can all appreciate just a bit of ground glass haze all over the lung. The next slide, please. I accept that these are all difficult to pick, and this is a rendering of the Mona Lisa, that had this occurred in times of Da Vinci, maybe he would have painted this picture a bit differently. The next slide, please. So some points to ponder. The next slide, please. So if you have to save life, you have to intervene early. You have to decide for the disease category, start a standard of care treatment plan, reassess in 12 hours, and either escalate or de-escalate your plan. And for donning and doffing purpose, you have to use a buddy system so that you don't get infected yourself. And we have to treat each patient individually and holistically. There is no single formula for all patients. So you have to understand this point. You have to cater for the psychological health of our patients. You have to limit face-to-face exposure, maybe up to 15 minutes at a stretch, then take a break and resume your rounds. Proning does help. Numerous studies have now shown this to be a fact. Glycemic control has to be strict. Asthma, COPD, CCF, acute kidney injury have to be taken care of. And the rest of the points are already, I think, we have touched upon them. Yes, we have touched upon them. May I have the next slide, please? These are some of the dreaded points. Incidence of silent DVT in couple of studies has been shown to be up to 43%, and incidence of silent pulmonary embolism is 17% in mild cases, 33% in severe, and up to 60% in the critical patients. And look at this next point. The incidence of bacterial and fungal super-headed infection in the second week onwards can rise up to 50% in critical patients. And supratherapeutic doses, we all know by now, of anticoagulation, numerous studies have come out to be so. Duration of therapy on discharge has to be 4 weeks on discharge. And this has been our practice. If you find it appealing, you can use it. That if we found to be a neuropredominant CRS, we switched to DEXA because of its better blood-brain barrier penetration. And if lung predominant CRS was present, we preferred IV methylpred just because it has been tried in COVID in the lung patient so far, and methylpred has slightly better penetration in the lung tissue. May I have the next slide, please? So don't get confused. Hydroxychloroquine versus non, steroids versus non, early went versus late, standard of care versus novel, evidence versus experimentation, guideline following versus out of the box thinking. These are all different groups of scientists who want to help patients. But since this is a war like situation and the virus and this illness is just 7 months old, we are all just learning and we are all just trying to understand how best to help patients. So whatever suits you, given that you cater for the side effects, the drug interactions, you can adopt any therapy or any of the plan that suits best for your patient. May I have the next slide, please? So what we learned was that a pandemic occurs but once in a lifetime, and the best made plans go out the window the moment the first patient crashes. And a bit of advice, cherish your colleagues, for these are the people of character who stood by you in this war. Befriend them for life if not already. Thank you all for doing your best in such times of panic. Pray, learn, think, meditate, help, enjoy, and above all, hope. Don't lose hope. May I have the next slide, please? And I believe we have come to the end. Any questions? And on this verse, I usually end my talk, that there is not for man except what he strives for. So do strive for learning and for helping your patients. This is the oath that each one of us took. Thank you all for your patient listening, and any questions that I may be able to help. Do you have any questions, please?
Yes, sir. Sir, this was an amazing presentation, very informative, and we have a lot of questions. We will try to take as many as possible. So if you're ready, I'll tell you the first question. Sir, so the first question from Mr. Zahid Hussain is, out of all the immunomodulatory drugs, which drugs had the best outcome?
If we consider among the immunomodulatory drugs, if we consider hydroxychloroquine, ivermectin, azithromycin, what we have seen is that hydroxychloroquine had the best chance, and we had already used it in a number of patients for quite a long period of time in malaria, and even in malarial prophylaxis in the parts of the country where the malaria is rampant. And by now we know its profile, its pharmacokinetics, its drug interaction, so we were pretty comfortable with it. And the one thing that the West dreaded about hydroxychloroquine or chloroquine was its prolongation of QT interval. And if you read a bit deeply, and especially if you read about it in Cochrane reviews, despite the fact that it has been touted to be a significant side effect in vitro studies, in vivo studies found that QT interval risk was less than 0.06%. So considering this low side effect incidence profile, we have used for about 2 months or so in our patient, And we just encountered one patient who had prolongation of QT interval, which was managed adequately on stopping the treatment. So as far as the immunomodulatory drugs are concerned, out of these three, hydroxychloroquine has the best chance of being cheap, easily available, extensively studied, and proven to be efficacious. Whether it works on COVID or not is another ballgame. And I believe I have answered. Yeah, the next question, please.
Yes, sir. So the next question by Mr. Farhan Faisal is awake proning. How does this help with hypoxia?
Proning. Okay. If you go back to your memories of lungs, we know that the main chunk of lungs, especially the whole complete lower lobes, are located posteriorly on the dorsal portion. And since ventilation perfusion mismatch is the main problem which hampers oxygenation in such patients, if you turn the patients prone, the maximum part of the lungs, they get a bit free from the pressure of the rest of the viscera and from the rest of the bulky lungs, and they have a chance of expanding better and responding to oxygen in a better manner. And it has been tried and tested in innumerable studies, and by now it has been recommended as a must-do thing even in those patients who are on ventilator. And it has to be done on such critical patients for up to 16 hours at a stretch. May I have the next question, please?
Thank you, sir. Ms. Alia Ali is asking, can you please address why COVID-19 antibodies are less effective over time?
I didn't get the question. Can you repeat, please?
Can you please? Yes, sir. Can you please these?
I can't hear you. Probably your screen is stuck.
Yes, I think she's having some connectivity issues. I will ask you. Alia Ali said, can you please address why COVID-19 antibodies are less effective over time?
Um, I couldn't hear you properly. If you can just get away from the mic a bit, your voice is reverberating. Yes, please.
Okay, sir. Can you hear me now?
Yes, please.
Okay. The question is, can you please address why COVID-19 antibodies are less effective over time?
Nobody is sure till now. The scientists believe that there are two types of antibodies, the neutralizing antibodies and the protecting antibodies. But since it's a relatively new disease, just 7 months old, so the antibody titers that the labs so far are able to measure, that titer dwindles pretty soon within a couple of months at best. However, quite a bit of evidence is now coming up that the protection capability after acquiring COVID is based more on the T cell subset, which so far we are unable to measure, and it relies less on the antibody. So, good news overall. Next question.
Thank you, sir. Our next question is from Dr. Sehrish Bey. From Imama Satar. Why do some people not develop antibodies after recovery?
Again, as I said, that nobody is sure, but what the mechanisms put forth so far are that the antibody production probably depends on how severe the virus hits you and how severe the immune system reacts. That would probably dictate on the titer of the antibodies. And secondly, the antibody tests that are in market at present are very difficult to standardize. Hence, you can find false positives and false negatives. And thirdly, we do believe that the majority of protection capability conferred after COVID is dependent on the T cells and not on the antibodies. And so far, we don't have any test to measure the T cell response on a commercial basis.
Thank you, sir. Another question is from Dr. Mohammed Irbaz. The question is, are asymptomatic COVID patients more vulnerable to severe COVID disease if there is a second wave of the pandemic?
I believe anybody's guess is good as mine. But we do believe so far, based on the science, that there has been almost no reinfection so far, even if we take China as the place where this disease started, and it is now 7 months down the line. There are no confirmatory evidence of a patient being reinfected, uh, despite the fact that sporadic cases came up on the internet that few doctors thought that they had contracted the disease again. But by now we know that these were the simmering cases, or those patients in whom CRS was triggered due to some other infection, or who had a complication of the disease, or who had lung fibrosis. And there are no proven cases so far which can be attributed to reinfection. So I hope that puts your mind to rest.
Thank you, sir. We have another question by Dr. Azizul Kader. Please shed some light on management of post-COVID fibrosis and also the type and duration of anticoagulation post-discharge.
Okay. Like I said, that post-COVID fibrosis can be due to multiple factors. If the patient was on vent, the most common culprit is post-ARDS fibrosis, which we know for long. And the other thing that is being put forward is AFOP, acute fibrinolysis with organizing pneumonia. And it is again a hyperinflammatory response of the body to the insult. And the third thing, which I believe is more rampant, is oxygen toxicity, which can result in fibrosis because we all put the patient on maximum oxygen and then we forget to taper it down. And that might be the reason. So based on these three reasons, what I believe is that if you find a patient whose X-ray or CT scan, comparative CT scan later on finds in which you find that reticular lines are increasing and the patient is progressing to fibrosis, you must initially rule out all the treatable things, which are a superadded bacterial infection, pneumocystis infection, a fungal infection, uh, oxygen toxicity, and you can give them a trial of high-dose IV methylpred. 120 milligram thrice daily, we even give to those patients who fall in the severe or critical subset. And you can later on even give as high as 1 gram daily for 3 days and see the response. And if you find a good response, you can taper off, continue steroids and taper them off over the next 4 weeks or so. And same goes true for anticoagulation. In the severe and critical subset in whom you start anticoagulation, you have to continue anticoagulation oral and steroids oral in a tapering dose for up to 4 weeks on discharge. Because if you taper these things earlier, there will be a rebound of CRS. I hope I have answered your question.
Yes, sir. Thank you. Sir, the next question is there any herd immunity?
Is there?
Is there any herd immunity?
I didn't get you, sorry.
Is there any herd immunity?
Herd. Is there any herd in religion? I didn't get the question.
Sir, they're talking about
Sorry.
herd immunity?
Herd immunity.
Yes.
Okay, a herd immunity. We have the Swedish example by now, in which they went all out for herd immunity, and by now they are facing the music, and their country is facing a number of patients. So herd immunity can only be achieved once 50 to 70% of the population get exposed to viral illness. And who knows, out of these 50 to 70% of the population, all the hospitals, the healthcare system will be overwhelmed, and people will die of even simple treatable things like diabetic ketoacidosis or myocardial infarction, because the health system would be overwhelmed. So I don't think, and the whole world doesn't think, that herd immunity is the way to go.
Right, thank you, sir. Sir, the next question is,
I have the
is
next
there
question.
any role, yes, sir. Is there any role of pulse therapy by methylprednisolone?
Pulse therapy, no role, because methylpred or dexa, whatever you may be, it has to be given for a couple of weeks once the patient is admitted, depending on how severe the illness is. And pulses don't help. A continuous maintenance dose of steroid is what we aim for, because the cytokine release from, once it's triggered, takes quite a long bit of time to settle down. And this response varies in various patient subsets, and there is no prediction rule. So I don't think any hospital, to the best of my knowledge, worldwide has tried pulse therapies. All have tried various doses of continuous and maintenance steroids. Next question.
Right, thank you, sir. Sir, the next question is, can we have access to the clinical trials which have been done in Pakistan? Where can we read them?
Good question. I believe we were all busy fighting this war, and being a resource poor country, we didn't have a separate departments. At least most of the hospitals didn't have separate research departments where a separate group of doctors were focusing purely on research. And I do believe that now, once the main thrust or the first wave is almost coming to an end, we will find a number of studies being published. Uh, Even in our hospital, we have about 40 different studies in various offices of publication. And pretty soon you'll have access to our own local data. And I was chatting with a dear friend from Karachi and Lahore the other day, and they are also trying to get their studies published. So pretty soon we'll have a quite good look at a local experience.
Right, thank you, sir. Sir, the next question is, what is the current criteria for proning of intubated patients?
Okay, there are two sets of doctors, one who go for early intubation and the other who advocate a late intubation. Once the disease started early on, early intubation was propagated, because they thought that it's an ARDS-like illness, and putting the patient on early on vent would take care of the oxygenation needs. But by now we know that late ventilation is more beneficial for the patient. The criteria are almost the same. If a patient is developing multi-organ drone, if the SOFA score, you can have access to SOFA score on Google or internet, is more than 12, or if you are failing to achieve a target saturation of 93% in the first week or 90% second week onwards, despite maximum oxygenation and CPAP or NIV available, or if the patient is going into septic shock, or if there is some other comorbidity which requires vent. These are the indications of ventilation as far as the whole body of evidence is concerned.
And sir, they were also asking about proning. So proning in the intubated patient.
Proning. Okay. Okay. Proning is very difficult in an intubated patient. You need approximately 7 trained staff members who will each have to play their coordinated role for an intubated patient to get prone. So, but I believe all the critical care centers in Pakistan are practicing as good as the international standards advocate us, and it is being practiced all over, and it is difficult, but it is doable, and it has shown benefit, and it is now being put in the heading of standard of care in critical patients because the evidence is overwhelmingly in favor of.
Right, thank you, sir. Sir, the next
I hope
question
I
is,
have answered.
yes, sir. Sir, the next question is, does Remdesivir work late in the disease process?
The next question, please.
Sir, the next question is, does Remdesivir work late in the disease process?
I didn't get you.
Can you hear me
I
now?
couldn't
Sir?
understand.
Does Remdesivir work late in the disease process?
I think we have lost some connection with Dr. Zil. That was a very wonderful presentation, and also he's back. Yes. So we can ask more questions.
We will continue with our question and answer session for now.
Can you hear me now?
Sir, can you hear us?
Can you hear me now?
Yes, sir. So, sir,
Yes,
the
I
next
can.
question.
Okay. Coming on back to Remdesivir.
Yes.
Remdesivir, as I told you, is supposed to work as far as scientific evidence is concerned in the first 10 days or so when the virus is in the body because it's an antiviral agent. There is just one center that's, to the best of my knowledge, in UK, which is prescribing Remdesivir as part of a trial in those patients who are coming to them in the 4th week or 5th week of illness just to see if it works in those patients or not. Other than that trial, the scientific evidence suggests that it should be given in just first 10 days or so. And the next
All
question,
right.
please.
Yes, sir. Vaccination trials in UK have proven to trigger immune response according to studies. Could it be a potential vaccine and be available soon?
To the best of my knowledge, there are 7 vaccines quite near to phase 3 trials. There are 3 vaccines which have shown quite promising results. But being a resource poor country, we should understand that even if these vaccines are available, say by September, October, or November, that is the earliest time frame that these pharmaceutical companies have shown, these will be available first to the first world countries, and maybe the earliest that it can be available to a country like Pakistan would be sometime summer next year, maybe. So we'll have to dig in deep and we'll have to maintain all these things, washing hands, maintaining social distances, wearing masks and protecting ourselves as well as the near and dear ones.
Thank you, sir. Sir, the next question is there any role of ECMO in critically ill patients?
ECMO, ECMO. Yes, there is a role of ECMO, but unfortunately, the technical know-how of ECMO is restricted to maybe just 3 centers in Pakistan, if I'm not wrong. And we haven't put any patient in our institute on ECMO. And a couple of my colleagues have done so in Karachi, but the result was not good, and the patient couldn't survive. So ECMO in the best center where the technical know-how is has shown to be beneficial in approximately 30% or so patients. But it is a last resort to those patients who are supposedly the H subtype of critical patients in whom it is very difficult to ventilate.
All right. Thank you, sir. So the next question, which is very commonly asked these days, is what are the chances of reinfection, and do we have any cases reported in Pakistan?
Like I already said that so far no case of reinfection has been reported in the world. The few, three to the best of my knowledge, cases that were touted as being reinfection turned out to be either a bacterial infection or a simmering CRS process being triggered by some other infection or a complication, chronic complication of the disease process. So nowhere in the world so far, even in South Korea where this term came up initially, later on it was proven to be a false alarm, and these were the reasons. So nowhere in the world reinfection has been reported so far.
Right. So we have a lot of other questions, but because there's a shortage of time, we will have to move on to the next presentation. If it's all right with you, and if we have time towards the end,
Thank you.
we can start
Yes,
the
thank
question
you.
and answer session. Thank you so much, sir, for the informative session.
Sure. Thank
This
you.
concludes,
Thank you
sir.
for having me.
This concludes our question and answer session
Thank you,
for
sir.
now. I would like to obviously thank Professor Zila Humayun for an amazing presentation and for sharing his valuable time and information with us. Mavish, over to you.
Thank you so much, Dr. Maham. Our second speaker for tonight is Professor Dr. Mohammad Khurram, who is the Dean of Medicine and Allied at Rawalpindi Medical University. He will be speaking on the following topics: COVID and diabetes, hypertension, asthma, chronic obstructive pulmonary disease, and typhoid. He will also be discussing care of cancer and systematic rheumatic diseases in COVID-19 pandemic. Allow me to please introduce Professor Mohammad Khurram to share his knowledge with us. Thank you.
Thank you very much for giving me this opportunity. Are you getting my slides?
Just a moment.
Okay, fine. So you are getting my slides. So today's session is about comorbidities and COVID-19 infections. So you may have gone through the list of comorbidities which have been just enumerated. That is diabetes, hypertension, obesity, systemic rheumatic diseases, asthma, and chronic obstructive pulmonary disease. So do not mind if I am concise, focused, and to the point, because each of these itself is an elaborated issue which needs longer version of presentation. Fine. So we will be talking about comorbidities in settings of COVID infection. So as far as COVID-19 is concerned, at the end of 2019, a novel coronavirus that was named severe acute respiratory syndrome coronavirus 2 was identified as the cause of cluster of pneumonia cases in Wuhan, China. By 2020, infection was with this virus led to pandemic that has spread throughout most countries of the world. In Pakistan, the first COVID-19 patient was noted on 26 February. Initial COVID infection were linked to Iran visit. In subsequent week, confirmed cases were noted at Rawalpindi and Islamabad as well. Till today, 25th July, we had 271,887 patients and 5,787 deaths. And the case or the closed case fatality rate in Pakistan is 2%. Just before we move further, we need to understand a few points. It is the pathophysiology, and this slide, although it's jumbled up, but it is showing some important things. One is that there is entry of SARS-CoV virus, and that is mediated through ACE2 receptor, the receptors which are in limelight nowadays. So it may be infect the endothelial cells with damage of the endothelial cells, or it may lead to damage to the alveolar pneumocytes. And damage at both sides will be associated with underexpression of the ACE2 activity, which in turn will be associated with the issues pertaining to degradation of angiotensin 2 and The damage to the pneumocyte will lead to damage of the alveolar vessel interface and then hyalinization. And this, along with the impact of the angiotensin effects, there may be increased platelet aggregation, there may be activation of plasminogen activated inhibitors, deficiency of prostacyclin and nitric oxide synthesis, along with accumulation and activation of mononuclear cells and production of inflammatory markers. All of these would be leading to enhanced microvascular thrombosis, inflammation, and all at the end we will be facing respiratory failure. So what is the impact of comorbidities on COVID-19 infection? In the largest meta-analysis that was of 89,238 patient, total prevalence of comorbidities in COVID-19 patient was 42%. It was 62% in ICU patient and 77% in expired patient. Similar results have been noted at our center and other centers as well. 20 to 50% of COVID-19 patients have at least one comorbidity with hypertension, diabetes, and cardiovascular, including cerebrovascular disease being most common. The increased prevalence of comorbidities increases the odds that COVID-19 patient will need ICU care or will die, especially if the pre-existing disease is hypertension, heart disease, or diabetes. So, presence of at least one comorbidity or more even so in COVID-19 patient is associated with poor clinical outcome. And this slide can give you an idea that how much are their comorbidities as far as the overall prevalence is concerned, as far as the ICU patient prevalence is concerned, and the fatal cases prevalence is concerned. As far as hypertensive is concerned, this is most prevalent, 32. For ICU patient, it is 27. We are talking about percentage. And for the patient who expired, it is 35. Afterward, it is diabetes and then coronary heart disease. And then there is a long list of these diseases. And of course, as they are prevalent in the total COVID population, the numbers are increasing in ICU patients and the fatal cases. So what are the risk factors for severe COVID infection? In addition to the viral factor, these are increasing age, hypertension, diabetes, cardiovascular disease, chronic lung disease, cancer, in particular hematological malignancies, lung cancer, and metastatic disease, chronic kidney disease, obesity, and smoking. I have highlighted few of the ones which I will talk. Of course, we will be talking about these in a focused way. So first of all, hypertension and COVID-19 infection. Just for the information of all, this is the blood pressure guidelines, measurements guidelines to differentiate somebody is having normal blood pressure or is having pre-hypertension or hypertension. So hypertension is the most common comorbid disease in patients with COVID-19. So we have already talked about the biggest meta-analysis. In that, 32% of the total, 26% of the ICU and 35% of the fatal cases had hypertension. This has been noted in other multi-center trials as well. So can we compare the outcome and severity of COVID infection and hypertension? Yes, this has been worked in many of the studies. So in non-survivors, the number of hypertension cases were 48% as compared to 24% in survivor in a study by Chen et al. Similarly, double number of hypertensive patients were noted as far as the survivors, non-survivor were considered in a study by Deng et al. And however, somewhat different results have been noted in a study by Mehra et al. As well. So what about the moderate, severe, and critical disease? So in patient with critical disease and moderate severe disease, the chances of being hypertensive are definitely much more comparative. Now the question is why hypertension is very common in COVID-19 patient with severe illness. The reason for this apparent association remains unclear. There have been several explanations that have been offered in this regard. Pre-existence hypertensive cardiac and organ damage may contribute to the severity of disease in hypertensive patient. There may be interaction between COVID-19 and commonly used antihypertensive medication, which may lead to severity of illness in these patients. Similarly, it may be simply due to the high prevalence of hypertension in older individuals, which have more propensity to have severe illness. Another thing which has been of focus in the same context is ACE2, which is angiotensin converting enzyme 2, which is considered to be master regulator of renin, angiotensin, aldosterone system, and its both reduced and increased function can induce systemic and pulmonary hypertension, heart failure, myocardial infarction, and diabetic cardiovascular complications. AC2 is highly expressed in heart, lungs, kidneys, and GIT, and it plays an important role in several cardiovascular and immune pathways. It has gained a widespread interest as the cellular receptor for COVID-19. So what are the biological effects of AC2? These are focused on the formation of angiotensin 1 to 7 from angiotensin 2. ACE2, unlike ACE, the original angiotensin converting enzyme does not convert angiotensin 1 to angiotensin 2, nor do ACE inhibitor block its activity, which is crucial for understanding of its biological properties and the effect of RAS inhibitors. The large confusion and panic regarding usage of AC inhibitors and ARB blockers erupted from two reasons: confusion between the ACE and ACE2 inhibitors, and some studies reported a significantly higher percentage of RAS inhibitor usage among COVID-19 patients with poor outcome. So, for understanding, let's review briefly that angiotensin is converted by the effect of renin into angiotensin 2. Angiotensin 1, and then it is converted by angiotensin converting enzyme into angiotensin 2 that affects on the angiotensin 1 as well as the angiotensin 2 receptors. And please note that the effect on angiotensin 1 receptor are negative while on 2 are positive. And the negative effects are vasoconstriction, inflammation, fibrosis, while on 82 these are positive: vasodilatory, anti-inflammatory, antifibrotic. The role of ACE2 is that it converts angiotensin 2 into angiotensin 1 and 7 and 1 in 9, and then it is the ACE that converts into 1 in 7. So this cycle becomes affected when there is usage of these receptors by the SARS-CoV virus for incorporation into the cells of the pulmonary and other areas. So the impacts of angiotensin 1 or 7 are just like the impacts of angiotensin 2 receptors, and these are mediated through mitochondrial assembly receptors. So their downregulation may lead to deficiency on this particular side. And you may note that AC inhibitors and angiotensin 1 receptor inhibitors may not have such impacts. So on one hand, increased ACE2 expression is associated with increased viral entry, while other hand, it would be associated with decreased angiotensin 2, increased binding to angiotensin 1 receptor, increased levels of angiotensin 1 and 7, and the possible beneficial effect as well. So we know that the patients with hypertension are having increased risk of getting severe version of COVID disease. So when these patients are admitted, we may divide these patients into two groups. One is the group that are diagnosed to be having that are diagnosed newly hypertensive, while the other group is of the person who are already diagnosed to be having hypertension. For those who are newly diagnosed, the choice of treatment for initiation is calcium channel blocker. As far as initiation with AC inhibitors or ARBs are concerned, we need to know that in these patients, repeat blood tests have to be ensured in order to assess renal functions as well as electrolytes, which should remain stable. So they can be also used, but we need to understand that depending upon the resources, we may modify their usage. So those patients who are already diagnosed to be having hypertension will not possibly require these tests unless they are moderately to severely ill. So those who are already on AC inhibitors or ARBs should continue these. However, sick day rules have to be remembered. The patients with COVID may develop anorexia, vomiting, diarrhea. They may have complicated illness requiring ICU admission, shock, etc. So in those cases, the medication have to be withdrawn. Otherwise, the management of hypertension in settings of COVID is almost the same as is generally. And the targets blood pressure are also the same. That is, we need to maintain the systolic blood pressure between 125 to 30 and the diastolic blood pressure less than 80. So we may simplify it like less than 130/80 without compromising the issues pertaining to COVID management. Okay. The next comorbidity in context of COVID infection is diabetes. And again, as I gave an overview of the hypertension related blood pressure range, this is the glycemia and its relation with diabetes, pre-diabetes, and the normal levels. So diabetic patients with COVID infection are at risk of more severe illness. COVID-19 appears to precipitate severe manifestation of diabetes, including diabetic ketoacidosis, hyperosmolar hyperglycemic state, and severe insulin resistance. Of course, we need to remember the role of cytokine releasing syndrome. That is, the body is having inflammation. There is role of steroids which are being given for moderate to severe illness, and they would be associated with increased gluconeogenesis, hyperglycemia, etc. There may be impact of the other medication which are being used for management of COVID infection as well. So just a comparison of fatality in total as well as diabetic patients. So as far as China is concerned, the overall fatality rate was 2.3%, while the fatality in diabetics was 7.3%. In USA, the total fatality rate was 6.2, while in diabetics it was 14.8. The similar results have been noted in UK as well. So that was about type 2 diabetes mellitus. As far as the type 1 diabetes and COVID-19 infection is concerned, the data in this regard is deficient. If infected, type 1 diabetics are likely to have more prolonged course than similarly healthy people without type 1 diabetes as seen in other infections. In the population cohort study from UK, patients with type 1 diabetes also had increased risk of in-hospital mortality compared with general population without known diabetes. So what is the link between the diabetes mellitus and COVID? So diabetes is associated with poor immunity, innate immunity. It is associated with pro-inflammatory cytokines. It may be associated with dysregulation of ACE2 levels. And of course, people use ACE inhibitors and ARBs. While the COVID infection is definitely can lead to beta cell damage. It through cytokines lead to insulin resistance. There may be electrolyte imbalances which may be leading to glycemia abnormalities, and of course potentiation. And of course there are medications which may affect the glycemia. So one is perpetuating the other, leading to the vicious cycle of hyperglycemia. So is there relation of hyperglycemia with COVID-19 severity? The role of hyperglycemia in the risk of severe infection in patients with diabetes has not been well studied. However, it has been concluded that poorly controlled diabetes is a risk factor for infection in general. COVID-19 can trigger an intense inflammatory response. It has been challenging to disentangle whether hyperglycemia and COVID-19 is a cause or as appear more likely a consequence of severe disease. Good glycemic control prior to COVID-19 infection and risk of severe infection has been focused as well. In one analysis, the patients who have higher glycated hemoglobin level at the start of illness, they were noted to be having higher mortality as compared to those who were not having higher glycated hemoglobin level at the time of COVID infection. So SARS-CoV infection lead to beta cell dysfunction and cytokine storm. This may lead to at admission hyperglycemia, worsening of metabolic control in patients with diabetes, and even new onset diabetes. This, when coupled with obesity, inflammation, coagulation, hyperglycemia leading to diabetic ketoacidosis, or the other version of diabetic complications, older age, hypertension, renal disease, is associated with poor outcome. There is role of COVID-19 treatment in hyperglycemia as well as diabetes. I have highlighted the one which are being used in our circumstances. So the conventional one is chloroquine and hydroxychloroquine. They are associated with hypoglycemia, and when they are being used with insulin and secretagogues, this effect is potentiated. As far as tocilizumab is concerned, it has been noted that it improves glucose profile, and of course that is because it has improvement or the positive effect on cytokine release syndrome. Steroids, as everybody is aware, lead to hyperglycemia and increase susceptibility to secondary infection. Remdesivir probably lead to increase blood glucose, but this has been not yet proven in more than few studies. As far as lopinavir and ritonavir are concerned, they may be associated with hyperglycemia and deterioration of glycemic control, and they may have interaction with statins, as is there for remdesivir. So how diabetic patients who are having COVID infection can have glycemia fluctuation? It may be because of irregular diet, reduced exercise, GI symptoms, which may affect dietary intake, leading to glycemic fluctuation. Stressful conditions like infection increase steroids production, which in turn will lead to impaired glycemia, and the use of glucocorticoids in patient management will have similar impact. There may be interruption or non-standard treatment with oral anti-diabetics in isolation wards, etc. That may also lead to glycemic fluctuation. Fear, anxiety, tension may increase glycemia, and induce glycemic fluctuation. COVID-19 can cause increased production of inflammatory markers that may lead to extreme stress in some severe and critical patients. So what we have as far as management of diabetes in COVID-19 patients is concerned. So can we use metformin? Metformin does not have risk of hypoglycemia. However, it has risk of lactic acidosis when the patient is in having respiratory failure, renal failure, or heart failure. DPP-4 inhibitors, they do not have risk of hypoglycemia. They can be used in wide renal function rates. They have potential anti-inflammatory effects, and they have been considered to have potential modification of COVID-19 binding to DPP-4 inhibitors. So SGLT2 do not have risk of hypoglycemia, but there is risk of hypoglycemia, electrolyte imbalance, and euglycemic ketoacidosis. For GLP-1 receptor agonists, there is no risk of hypoglycemia. There is some potential anti-inflammatory effect, but there are risk of GIT side effects and aspiration as well. Sulfonylurea are definitely not recommended because their risk of hypoglycemia and potentiation of effect with other anti-diabetic agents are considered. Pioglitazone is also anti-inflammatory, has also anti-inflammatory effects, and however, it may be associated with risk of fluid retention and heart failure. So what possibly we have? We have insulin in various versions and in various dosing, which can be used to treat glycemic abnormalities in patients with COVID-19 infection. However, we need to understand that keeping in mind the glycemic resistance to insulin, the dose may be higher as compared to the normal situations. So what should be target glycemia and the goals of treatment when we are managing a diabetic with COVID infection? These are to avoid hyperglycemia and hypoglycemia, avoid volume depletion and electrolyte abnormalities, and ensure adequate nutrition. A blood glucose target of 140 to 180 milligram, that is equivalent to 7.8 to 10 millimole per liter, is the one which is required. So what may be challenges? The challenges specifically in those patients who are isolated may be that there is shortage of medical resources, there is panic, there may be shortage of supplies, etc., which need to be managed. So what are the key points as far as the COVID-19 and diabetes are concerned? People with diabetes developing COVID-19 are at increased risk for complication and mortality. Adherence to healthy diet and lifestyle and access to healthcare is limited by infection control measures in the community, such as lockdown, self-isolation, and quarantine. General precautions to prevent COVID-19 infection are critical for people with diabetes and their families. Patients with multiple comorbidities need extra caution. Continuation of good dietary practices, safe physical activities, and regular glucose monitoring should be encouraged. Measures such as telemedicine services and drug dispensing should be ensured. People with diabetes who develop COVID-19 should continue their routine medication unless the illness is severe. For severe COVID-19 patients, glycemic control is best achieved with insulin. SGLT2 antagonists or inhibitors are best discontinued unless the illness is mild. AC inhibitors, ARBs, should be continued unless contraindications is there. Individuals' decision can be made regarding aspirin and statins. Now it's the time for obesity and COVID. As far as obesity is concerned, COVID-19 pandemic has led to worldwide research efforts to identify people at greater risk of developing critical illness and dying. Initial data pointed towards older individuals being particularly vulnerable as well as those with diabetes mellitus or cardiovascular diseases including hypertension, respiratory or renal disease. Increasing number of reports have linked obesity to more severe COVID illness and death. So what is the risk associated with obesity in COVID-19 infected patients? So risk of invasive ventilation in COVID patient increases 7-folds if the BMI is more than 35 compared with BMI less than 25. One need to understand that COVID patients who are less than 60-year-old age and whose BMI was 30 to 34 or more than 35 were 1.8 and 3.6 times more likely to be admitted to critical care units as compared to the patients whose BMI was 30. So more obese, more chances of getting severe COVID infection. It has been suggested that obesity may be unifying risk factor for severe COVID infection, reducing protective cardiorespiratory reserve as well as potentiating the immune dysregulation that appears at least in part to mediate the progression to critical illness and organ failure in proportion of patients with COVID-19. Whether obesity is independent risk factor for susceptibility to infection requires further research. How obesity leads to damage? There are three main things: cardiometabolic and thrombotic, lung, pulmonary, and inflammatory. So as far as the cardiometabolic and thrombotic impacts are concerned, obesity is associated with hypertension, diabetes, coronary artery disease, and a number of diseases. It will be potentiating multiple cardiovascular risk factors. And of course, it is associated with insulin resistance and reduced beta cell function that limits ability to evoke an appropriate metabolic response on immunological challenge. There is issue pertaining to integrated regulation of metabolism that requires complex cellular interaction and effective host defense, which are lost in obese patients, leading to functional immunological defects. COVID-19 may also directly disrupt beta cell function, and obesity in turn will enhance thrombosis, and COVID infection can be associated itself with prothrombotic state, leading to potentiation of the impacts and effects. Obesity is definitely detrimental as far as the lung functions are concerned. It is associated with diminished FEV and FVC. Higher relative fat mass is also linked to the similar adverse changes. Please note that in Asians like us, there is higher relative fat mass. Our BMI may not be high, but our chances of having visceral fat and obesity-related complication may be higher as compared to the Western world's persons with similar BMI. With extreme obesity, care of individual admitted to hospital, specifically the intensive therapy units, become difficult. And as has been discussed earlier by Professor Zille Humayun, if we need to prone a patient who requires 7 trained person, so how many person would be required to have prone nursing in a person who is markedly obese? The third component which obesity can lead is inflammation. So obese person have basal inflammatory status characterized by higher circulatory cytokines. Adipose tissue itself is pro-inflammatory as it is associated with increased expression of cytokines and particularly adipokines. Obesity is independent and causal risk factor for development of immune-mediated diseases like psoriasis, and immune consequences on additional environmental provocation are also a link. Obesity as the obesity impairs adaptive immune responses to influenza virus, and conceivably it could do so in COVID-19 infection as well. Obese individuals may exhibit greater viral shedding, suggesting potential for great viral exposure, especially if several family members are overweight. So that is the summary version of obesity's links with the COVID infection's severity. So obesity affects the lungs by reducing, by having impact on FEV1 and FEVC. It has cardiovascular impacts, like it increases the cardiorenal stress. It may be associated with hypertension, thrombogenics potential, and increased chances of diabetes. And the other side, it is associated with dysregulated hyperimmune response, increased chances of viral load and viral shedding, and both would be associated with lower cardiometabolic and cardiorespiratory metabolic reserve and immune hyperreactivity, which may lead to severity of COVID infection. So what may be the issues in COVID-19 infected obese patients? Management. The intubations may be challenging. There may be difficulty in obtaining imaging related diagnosis. It would be definitely difficult to position and transport these patients. They may not do well when prone. There may be issues with rehabilitation, and in some cases, we may have to require bariatric hospitals beds. So what to do in these cases? So probably prevention is the best thing. That is reduction in exposure risk. We can't do lifestyle modification, exercise, diet modification, weight loss, and medications because when the COVID-19 infection has set in. However, these can be done beforehand. And one need to understand that lockdowns are associated with weight gain. And what to do when these patients are being managed at hospital. The thing is, one should explain the risk. The management is always multidisciplinary. The healthcare personnel needs to be trained in management of these patients, specifically with reference to the issues which may be noted in these patients' management. And of course, this requires provision of required human resource as well as equipment. The next component in our today's talk is COVID-19 infection and COPD. So chronic obstructive pulmonary disease or COPD is a common, persistent and preventable dysfunction of the lung associated with limitation in airflow. It is a complex disease associated with abnormalities of the airway and or alveoli, which is predominantly caused by exposure to noxious gases and particulates over a long period. With a global prevalence of 250 million cases of COPD in 2016 and 3.17 million, 5% deaths in 2015, COPD was ranked by WHO as third leading cause of death, especially in lower and middle income countries. This burden is predicted to grow due to mainly increased global exposure to tobacco, aging population, poor awareness, and inadequate access to diagnosis. COPD exacerbation are major events in the natural history of the disease associated with worsening of symptoms, often resulting in hospitalization and poor prognosis. Various factors have been described to contribute to acute worsening of COPD. However, viral infection remains the major or the main trigger, including seasonal coronavirus. So patients with COPD who have COVID infection will be having increased morbidity and mortality. Why? Because viral infection in COPD patient increase systemic inflammation with slow recovery of reported cases. In addition to the effect of COVID-19, patients with COPD may have various comorbidities. some of which will be associated with increased risk of hospitalization. COPD patients with severe COVID-19 are older and had more coexistent comorbidities. So all these things will add up, leading to severity of illness, increased chances of morbidity and mortality. COVID diagnosis in COPD patients will also be somewhat challenging due to symptomatology, because cough, fever, shortness of breath, these may be there in COPD patient commonly. It is often delayed as patients present with fever, fatigue, and other systemic symptoms, and respiratory symptoms are relatively light. After 6 to 7 days, rapid deterioration of lung function in these patients may occur. Once infected with COVID-19, lung function in COPD patient can deteriorate rapidly, leading to respiratory failure. In a small number of patients with COVID-19 pneumonitis, especially the elderly, COVID-19 patients may initially present with delirium. So what should be management plan as far as these patients are concerned? So management plan can be there for patients who are being managed at home or who are being managed at hospital setting. People with COPD should continue their treatment for COPD as usual during the COVID-19 outbreak. Individuals should make every effort to avoid COVID-19 exposure using standard methodology. They should have medication supply. If they require oxygen, they need to have its adequate provision. They need to avoid triggers that makes their symptoms worse. As far as nebulization at home is concerned, caution is advisable to avoid spread of COVID-19 to other members of the household. Management plan should be there with healthcare team. This can help patients keep track of medication, monitor COPD symptoms, and check symptoms that are not worsening. And of course, the hospitalization may be required. As far as the hospital management is concerned, all maintenance medication necessary to maintain control of COPD should be continued, including bronchodilators, inhaled glucocorticoids, and when indicated, roflumilast and azithromycin. There is no good evidence that inhaled glucocorticoids have adverse effect on the course of COVID-19 infection. In addition, the usual guideline for prompt initiation of systemic steroids for a COPD exacerbation should be followed, as delaying therapy can increase risk of life-threatening exacerbation. For patients hospitalized with COVID-19 infection, use of inhalers is preferred to nebulized medication to reduce the risk of aerosolization and spreading the virus. The next component which will be discussed briefly is asthma in setting of COVID infection. The meta-analysis which I shared with you earlier showed that only 3% of the total patients out of 89,000 patients were asthmatic. 0% were admitted to ICU and there was no fatality. However, we need to know that as community testing for COVID is still limited, it is difficult to say with certainty if any group is more or less likely to contract the disease like asthmatics. Most data on disease prevalence and outcome comes from the people hospitalized with COVID-19 that may skew the issue. Data from US and China show that prevalence of asthma in COVID-19 population is below approximated expected general population's prevalence. At present, there is no evidence suggesting that people with asthma are any more likely to contract COVID-19 than anyone else. There is an interesting point in this regard as far as asthma and COVID infection is concerned. ACE2 expression is lower in people with high level of allergies or allergic asthma potentially making their respiratory system less vulnerable to viral intrusion. However, some research have also shown that this is not the case for non-allergic version of asthma, who might actually have increased expression of ACE2 receptors, as has been said by various experts. When we know that asthma does not appear to be a strong risk factor for acquiring COVID infection, we definitely know that poorly controlled asthma will lead to more complicated disease course for those with COVID-19 infection. Maintaining good asthma control helps minimize risk for an asthma exacerbation and associated need for interaction with healthcare system, which could lead to exposure to COVID-19. Every effort should be made to avoid exposure to COVID-19 and all regular medication necessary to maintain asthma control, including inhaled steroids, oral glucocorticoids, biological agents, should be continued during the COVID-19 pandemic. Inhaled corticosteroids or biological agents used for asthma do not have an adverse effect on the course of COVID-19 infection. For those taking long-term oral glucocorticoids, abruptly stopping this medication can have a number of serious consequences. Usual guidelines for prompt initiation of systemic steroids for asthma exacerbation should be followed, as delaying therapy can increase the risk of life-threatening exacerbation. For patients with COVID-19 infection, inhaled asthma medication should be given by inhaler rather than nebulizer when possible to avoid aerosolizing the virus and enhancing the disease spread. Okay, so we are going to the next component, that is rheumatology and COVID-19 infection. So as far as the systemic rheumatic diseases and COVID infection is concerned, presence of rheumatic diseases alone is not known to be associated with increased risk of developing COVID-19 or with an adverse outcome from the infection. Patients with various rheumatic diseases have higher prevalence of several comorbidities like cardiopulmonary, renal, hypertension, diabetes, etc. And increasing age may be an added insult in the same context. In one series of 86 patients in New York with immune-mediated inflammatory diseases diagnosed with COVID-19, the proportion of patients requiring hospitalization was similar to that of infected patients in the general population. Limited data suggests that patients with active rheumatic diseases may have increased chances of COVID-related complications. It is not known whether there is association of any specific rheumatological treatment with increased risk of COVID-19 or its complication is there, although rheumatic disease therapies have been associated with higher risk for other infections. Variable observational studies results show that there may be increased risk of COVID-19 and its complication in patients receiving systemic rheumatic disease therapies, and others suggested a decreased risk. Prednisolone doses more than 10 mg have been noted to be associated with increased risk of hospitalization in rheumatology patients with COVID infection. Tumor necrotic factor inhibitors have been associated with lower risk of hospitalization. Conventional disease modifying agents, either alone or in combination with biological, have not been found to be associated with increased risk of hospitalization, nor was the use of NSAIDs. There has been potential role of hydroxychloroquine in COVID therapy, and still a number of studies are going on, and many of the results of studies have been promising, while the other have shown not good results. So many of the observation that has been made is that many of the rheumatic disease patients with COVID-19 have been taking hydroxychloroquine at the time when they were diagnosed with infection. So that may go with the notion that hydroxychloroquine may not work. As far as features are concerned, clinical features of COVID-19 among patients with systemic rheumatic diseases are variable and not known to be different than patients without these underlying diseases. Type of rheumatic disease or the intensity of immunosuppressive agents used influence the clinical presentation of COVID-19. Symptom mimickers are there, like fever in SLE, headache in giant cell arthritis, GI symptoms in spondyloarthropathies, dyspnea and ILD associated with rheumatoid arthritis, systemic sclerosis, or SLE, stroke in antiphospholipid or antibody syndrome, etc. And chilblain-like lesions in as far as they in SLE may be seen similarly in COVID dose. So medications for like sulfasalazine may cause GI symptoms and methotrexate may cause pulmonary abnormalities, which may lead to difficulty in diagnosis as far as the clinical features as well as the investigative features are concerned. So what to do in COVID infected patients who are asymptomatic? For these patients, hydroxychloroquine, chloroquine, sulfasalazine or NSAID may be continued. Methotrexate or leflunomide should be discontinued. This is somewhat questionable. This must be assessed on case-to-case basis, weighing the potential risk of infection and is equally against the possible risk of rheumatic disease flare-up during the period the drug is held. For most patients who are asymptomatic but thought to be recently exposed to COVID-19, temporarily stopping cyclophosphamide, mycophenolate, azathioprine, tacrolimus, and the other biologicals pending a negative test result for COVID-19 or after 2 weeks of symptom-free observation can be done. These agents, however, may be continued in individual cases, particularly in those for whom there is increased risk of disease flare. Continuation of the use of IL-6 inhibitor in this setting needs to be individualized because tocilizumab is used for management of cytokine release syndrome. As far as the symptomatic infection is concerned, one should temporarily discontinue sulfasalazine, methotrexate, leflunomide, and immunosuppressive medications, biological agents during the period of active infection. In cases where the patient have active or organ-threatening rheumatic disease, continuation of these medication may be required on individualized basis by a multidisciplinary team. Another exception is discontinuation of a particular agents that are selected in selected patient in whom an anti-rheumatic therapy also has value of the treatment of features of COVID-19 like tocilizumab, etc. And of course, as I mentioned, that IL-6 inhibitors are being used for management of cytokine release syndrome. For patients with severe respiratory, cardiac, or renal involvement, NSAID should be discontinued. Patients treated with steroids should remain on the same dose to avoid acute rheumatic disease flare and the complication of adrenal insufficiency. Steroids, including both systemic and intra-articular glucocorticoids, should be used consistent with best practice employed in patients without COVID-19. Possibility of other infection should be excluded before joint injection if it is required, and this approach should be used as sparingly as possible. When in these patients COVID infection is over, one should restart the immunosuppressive medications when they are asymptomatic or at least 2 weeks have passed since documented infection. As far as the role of repetitive PCRs are concerned, one needs to understand that the PCR may remain positive for a longer period because of the presence of dead particle in the tissue. Okay. The next component of this discussion is COVID-19 infection and cancer care. So cancer care in COVID-19 setting is a perplexing issue. There is risk of death from cancer versus death or serious complications from SARS-CoV infection, like higher lethality of COVID-19 in immunocompromised host, people who have to get surgery or chemotherapy or radiation therapy, they are generally delayed in settings of COVID-19 pandemic. Risk, because there is risk of contracting COVID-19 that may outweigh the benefits of cancer treatment. There may be inadequate supplies of PPE for healthcare providers, limited hospital capacities, including ICU beds, and lack of point-of-care testing and seroprevalence data, which may further complicate the difficulty of managing cancer patients with COVID-19. So malignancy has been noted in up to 3% of the total, 5% of ICU, and 5% of the fatal cases. In China, the incidence of COVID infection in oncology patient was 0.79 as compared to the cumulative incidence in community that was 0.37. In US, 6% of the hospitalized COVID-19 patients had cancer. In Italy, 8% of the ICU patients had active or prior history of malignancy. 20% deaths from COVID-19 in all of Italy were because of were in patients who had active cancer. The likelihood of severe illness and death from COVID-19 is higher among adult patients with cancer, particularly those with hematological malignancies, lung cancer, metastatic disease, and those with other comorbidities. One thing is which patients who are going to be managed for cancer need to be tested. So any cancer patient who is exposed to COVID-19 or is symptomatic should be tested. Infectious Disease Society recommends that COVID-19 tests should be done before immunosuppressive procedures regardless of a known exposure to COVID-19. And the immunosuppressive procedures are cytotoxic chemotherapy, solid organ or stem cell transplantation, long-acting biological therapies, cellular immunotherapy, or high-dose steroids. Selective testing based on immunosuppressive potential of specific regimes like MVAC, methotrexate, vinblastine, etc., or cisplatin etoposide, but not for less myelosuppressive regimes such as emcitabine, docetaxel monotherapy, or single agent immunotherapy can be considered. So what should be approach in COVID patients? In general, immunosuppressive cancer therapy should be withheld in patients who test positive for COVID-19. Some oral non-immunosuppressive therapies such as hormonal therapies or drug targeting activating mutation medications may be continued on case-to-case basis. Hydroxychloroquine and AZT zidovudine combination needs to be avoided. Stage of disease, age, severity of COVID-19 and comorbidities should be kept in consideration when managing these patients, specifically in ICU setting. Goals of care and advanced care planning, especially for those with advanced disease, should be discussed. Things like differentiation of lymphangitic spread, medication pneumonitis, and COVID-19 should be kept in mind while these patients are being managed. The cancer treatment should be started after improvement. One should keep in mind that in these patients there may be persistent viral shedding. Risk of exposure on infection with upper aerodigestive tract procedures, whether they are diagnostic or therapeutics, for ENT, endoscopist, ophthalmologist, dermatologist, and plastic surgeons working on the head and neck area should be kept in mind when these patients are being managed. So, lastly, we will be talking about the enteric fever and COVID infection. So, diagnosis of fever in region like us has always been challenging task. There are large number of febrile diseases which are prevalent here, like malaria, enteric fever, dengue fever. And as everybody would be knowing now, COVID-19 is going and probably dengue fever may be coming. So with COVID-19 added to the mix, differentiation between these diseases becomes even more difficult. Due to physical distancing measures and PPE requirement, COVID-19 related requirements, there is limited access to the healthcare. As far as typhoid is concerned, it is a public health concern mainly in countries like us due to poor sanitation and unhygienic environment. It is a bacterial infection caused by Salmonella entericus, and it is characterized by fever, headache, rash, fatigue, and abdominal pain, which are common clinical features. And these may be mixed or confused with the clinical features of COVID infection. And its transmission is through intake of contaminated water and food with infected persons species, that is fecal-oral route. So one needs to understand that in isolation facilities, if the disease is there, it may spread. According to WHO, globally 11 to 21 million people get infected from typhoid and 128,000 to 161,000 die every year. In Pakistan, in this June, 20,000 typhoid cases have been reported, and the estimated risk attack rate of typhoid in our scenario has been calculated to be 15.5 per 10,000 population. And our country is definitely at the risk of XDR or extremely drug resistant typhoid outbreaks. And we are the country where typhoid conjugate vaccination is being introduced or as the first country. So what are the challenges as far as the typhoid and COVID-19 pandemic is concerned? So one is pandemic, the other one is not only endemic, but it converts into epidemic as well. So there may be difficulty in differentiating both diseases due to common symptoms. One needs to understand that in scenarios like us, the enteric fever is mainly diagnosed on basis of serology rather than the blood culture. So appropriate diagnostic methods should be used, as overdiagnosis may be associated with overusage of azithromycin, and along with its usage in COVID-19 patient can lead to more emergence of XDR typhoid, and there would be difficulty in management. And of course, there are possibilities of outbreaks in COVID isolations, and so one should focus on prevention and focused management in these patients. So after you have gone through important principles of comorbidities management in setting of COVID-19 infection pertaining to diabetes, hypertension, obesity, asthma, chronic bronchitis, rheumatological illnesses, malignancies, the best thing is that appropriate general preventive steps are employed so that these patients are not exposed to COVID-19, as they have more or higher chances of getting infection, and as well as infection related morbidity and mortality. So general preventive steps are the mainstay. These are that stay home except for essential medical care. If absolutely necessary to go for spatial distancing, avoid contact with others wherever possible, go for the routine practice of washing hands, make sure to have enough food and every medication supply. And if people live with others who are leaving and entering home, make sure they frequently wash their hands and do preventive steps themselves. And if people require external help from healthcare visit, ensure that these individuals are taking all necessary hygienic precautions. Clean and disinfect surfaces that people touch frequently. Avoid touching the face with unwashed hands, and cover while you cough and sneeze. So, with this, my presentation is over. Jazakumullah khair.
Thank you, sir, for your presentation. It was extremely informative. With your with your permission, we would like to now ask you some questions, if that's okay with you.
Why not? I will try my best to answer those.
All right, sir. So the first question from Dr. Usman Javed is, regarding treatment, could we give antibiotics to an asthma patient with the infection as prophylaxis against opportunistic bacteria?
Using antibiotics in asthma settings is generally not required unless there is lung damage for which you are going to use medications for prevention of infection. So generally it is not required.
All right, thank you, sir. The next question is, could you touch upon how obesity increases viral load in the breath and viral shedding?
Fine, that's interesting question. When I looked at this study, they were also not sure why these obese patients are having increased viral shedding and why they are having delayed viral shedding, and they are not becoming negative as early as compared to the general population. The pathogenesis is same. It is probably the immunoregulation which is affected by obesity, the inflammatory markers, etc.
All right, thank you, sir. Sir, the next question is, leptin levels are high in obese people. Does leptin level have any role in a COVID patient?
This has,
in the management?
as far as many of the questions, we should understand that many of these things have not been worked out because of the fact the disease is not much older. So probably studies will focus on these, and then we can have some answer in this regard.
Thank you so much, sir. Another question is it more difficult to diagnose COVID in COPD patients with pre-existing lung fibrosis and pre-existing infective changes on X-rays?
Very right. The patients who are already having lung damage, they would be differentiated on the basis of the clinical feature. That is exacerbation of the features, which may itself be because of the disease or because of the COVID infection. Number two, it would be differentiated on the basis of the radiological features. That is, if we have previous X-ray, CT scan, they may be compared with the current one. And lastly, the most importantly, we know that the COVID infected patients are asymptomatic as well. And it's only the PCR testing which will help in making the diagnosis in these patients.
Thank you, sir. Another question is from Dr. Masa. She's asking if it is advisable to nebulize asthma or COPD exacerbation patients with respiratory distress in ER, given COVID status is unknown.
When we are managing such patients, we have to keep in mind that if nebulization is necessary, we may take appropriate preventive steps, that it may be done in isolation in a COVID area, specific area. However, every patient of asthma will not be having COVID infection. As I already talked, that the asthmatics were among the minor component of patient with comorbidities. However, appropriate preventive steps should be done when we are nebulizing these patients, and ideally we should avoid these when we are managing in general emergencies.
Thank you so much, sir. Another question is from Dr. Ali Ara. Is peak flow still effective in triaging any exacerbation of asthma when suspected to have COVID symptoms?
Can you repeat the question?
Yes, of course, sir. Is peak flow still effective in triaging any exacerbation of asthma when suspected to have COVID symptoms?
Peak flow meters usage in patients who are having suspected COVID infection. Highly, it should not be done.
Sir, another question is, if a COVID patient is intubated, it is very difficult to extubate once he is on ventilator. Should we extubate and discharge on home BiPAP or wait for complete recovery, since after extubation, the patient again goes to carbon dioxide narcosis and may need reintubation?
Okay, fine. So you are talking about the patient who are having prolonged course in the ICU and they are being ventilated. And the question is, on improvement, they should be discharged home on BiPAP. Of course, we can discharge the patient only if they have improved. They are maintaining oxygenation. And
Okay, sir.
otherwise, how can we discharge them?
Yes, sir. Yes, sir. Another question is, which steroids are better in management for respiratory symptoms in an asthmatic patient with suspected COVID? Hydrocortisone, dexamethasone, or methylprednisolone?
You need to understand that we are differentiating the steroids on basis of their anti-inflammatory effect. So hydrocortisone has less anti-inflammatory effect. Similarly, prednisolone has less, but the dexamethasone or methylprednisolone would be having more. And similarly, these potentials would be focusing on the severity of illness. Generally, as you all know that in patient with asthma, we use prednisolone, not dexamethasone. But when we are suspecting a patient to be suffering from COVID infection, we should confirm it, and then we should go for dexamethasone or methylprednisolone appropriately.
Okay, sir. Thank you so much. Another question is, how to differentiate between symptoms of acute exacerbation of asthma and COVID-19 in asthmatic patients?
How to differentiate symptoms of
Acute
COPD and
exacerbation of asthma and COVID-19 in asthmatic patients.
the patients who are having acute exacerbation of asthma generally have increasing shortness of breath, increasing wheeze, they are unable to talk, etc. While the patient who will be having COVID infection generally would be having febrile illness, they may be having aches and pains, and along with this, they generally have cough and shortness of breath. Clinically, the person who is having asthma would be having more chances of wheezing as compared to the patients who are having singly COVID infection. However, when they are coexistent, it would be definitely difficult to differentiate whether it is simply COVID infection or it's exacerbation of COVID, exacerbation of asthma. So you have to differentiate based on the clinical features, history, clinical examination, radiological findings, and the PCR test.
Okay, sir. Sir, another question is, have there been any comparative studies regarding safety profiles of various DMARDs in rheumatic patients with COVID-19 symptoms?
Till now, I am not sure of such studies.
Okay, sir. Sir. That ends our question and answer sessions. Over to you, Dr. Maham.
Thank you, sir, for your valuable time. This concludes our session for tonight. I would like to thank all the professors for giving us their time and valuable information. Thank you to the participants for joining us. We hope that you have gained as much as we have through these sessions. Please do not forget to fill the feedback forms, as certificates will be distributed based on that. Thank you, Marvin, and thank you to our team in the background who have been supporting us throughout the series. That's all from me. Thank you.
Thank you so much, Dr. Maham. It was wonderful hosting with you. Thank you so much to both of our speakers. With such beneficial information, the presentations were amazing and very informative. All the participants were very eager and they had so many questions to ask. Thank you so much to all the participants for tuning in. We hope to see you on our third and last session of medicine, in which we will be hosting. Our first speaker will be Dr. Samina Fazl, who is a clinical nephrologist at Baylor Medical Center and will be addressing kidney in COVID. Our second speaker would be Dr. Omar Rahman, who is a neurocritical care consultant and also the assistant professor of medicine at Indiana University, USA. He will be talking about strokes in COVID and critical care of patients during this pandemic. Thank you so much to the team, on screen and off screen. Thank you, Mr. Yazdani, Dr. Amna Pirzada, and Dr. Ibrahim. During this pandemic, while we are practicing social distancing, these series are an attempt by VFP, Yardim, and RMU to stay connected and share knowledge with each other, just as our speakers did tonight. So do stay social online as we face and address the pandemic together. Thank you once again, Mr. Yazdani, and thank you once again, Professor Khurram. Thank you again on the behalf of our team, VFP, Yardim, and RMU. Hope to see you all tomorrow, inshallah. Allah Hafiz.